We have been sent a case today. This is a relatively, actually pretty new user, and this is his first virtual planning and guided case. And he would like to have a second set of eyes take a look at this. He was able to upload the case via our case upload section, and then we're going to go ahead and take a closer look at this. So the first thing I check when I'm working with new people is I take a look at the overall quality of the scan, and everything looks to be pretty darn nice here. There doesn't seem to be any movement. The only glaring thing I see is that either the team member, the office forgot to remove the patient's earrings. So while that doesn't affect anything too much here, it's just we need to make sure that the patients remove any neckwear, earrings, any of those things, nose rings that could possibly create some scatter and affect the overall quality of our scan. So I would just have a quick conversation with our team members to remember to do that. Second, I take a look at the scan and I try to determine what type of guide are we going to create. And in this case, I look at this and I see just a couple of restorations, lots of natural teeth, and I would say that this is a great case to do what we call an Opti guide. That is a digitally fabricated guide made directly by Sirona and CCAT. If there were lots of metal artifact on many of the teeth, then we would have to go with a traditional or classic guide. Um, and I would like to back up 1 second here. The other thing that I noticed in this scan is the patient doesn't seem to have their teeth separated. Now, this could be a class 3 bite that could be causing the appearance of that, but typically in the posterior, I would see some separation. It is our preference and recommendation that we have the patient use the bite stick when they have teeth uh, to make sure that we create some separation. This separation allows the CEREC data to be easily well integrated and allows just things to be a little bit better and more clear for implant planning. So I would certainly have my team look into that. With that all being said, the next thing that I'll do is I'll evaluate the overall quality of the CEREC integration because at the end of the day, if the integration isn't good, and the way I do this is I'll go to the axial view and I'll scan up and down until I see the tops of the teeth. And here's where I get concerned about not having separation. See how we have the upper teeth and the lower teeth? In an ideal world, we want some separation between them. So the use of the bite stick is quite important here. But the nice thing we can see here is as we go through this, we can see that our CEREC data is very well aligned around these teeth. So despite not having the bite stick, despite having the earrings in the photographs, we're still able to get good accurate alignment of the CEREC data, meaning that we will be able to fabricate an OptiGuide from this scan. So now let's go ahead and take a look at the implant positions. I'm going to start on tooth number 19. It looks like the dentist is using a Straumann tissue level implant. I'm not overly familiar with the Straumann tissue level implant, but nonetheless, we'll do our best to go through that. Personally, I'm a big fan of bone level implants. So what I'll do is I'll duplicate this plan and then we'll walk through everything. Okay. So my question on this with a tissue level implant is how are we going to build our emergence profile here if our implant is this high? Um, I just, I don't have as much control over the emergence profile. Also, the other question I have is where do we put the tissue level implant? Do we put it right there? Or do we leave it where it was? So these are things that I'm simply just not familiar with. So I will base it that the height of it is fine. I will just go more on the location of the implant. So one of the things that I notice in this particular plan is in looking at the axial view and also looking at the cross-sectional view here, we can see that our central groove, again, if the CEREC data is designed correctly, is right here, but yet the long axis of our implant is going a little bit through the buccal incline ridge here. So I would have a tendency to tilt this implant back to get that more aligned with the center. Okay, and then from the axial view, And just let me show you from the axial view. Here's the original plan. In the axial view, you can see that the implant long axis is coming here almost from, if you design this tooth into four quadrants, almost into the mesiobuccal quadrant when we want it to be dead center here. So again, this is more in line with being in center. And then I would say that we're a little bit closer to the mesial than we are to the distal. So I would likely in this particular case, actually, if you take a look here, what we can see is that our occlusal plane is headed up. So what I would do is I would tilt this implant to the distal hair, just like so. That will allow me to center it in the axial view, and that will also allow me to get a more level occlusal plane there. The only other thing that I see in this particular plan is we're going to have some implant exposed here on the buccal, and we're going to have quite a thin lingual cortical plate here. So I would consider maybe moving that over like so, and considering doing some grafting. Depending on your comfort and your personal preference, you may want to do pre-implant grafting, or you may want to do grafting at the time of surgery. So hopefully that helps and makes sense on site number 19. And again, as we go to site number 30, one of the things that immediately strikes me here is if we take a look, we can see how little space we have on the lingual, but we have more space there on the buccal. My preference is to try to, without compromising the restoration support, try to get this a little bit more centered. So I would probably do something more along the lines of this, and then move the implant over back to the central groove, just like so. And now we have more bone surrounding the implant all the way around, maybe like that. Okay. Again, this site looks a little bit more ideal, ready to go. We are quite close to the nerve, assuming that that map is correct, and that mapping seems to be correct. I personally may not be that comfortable getting that close to the nerve, even with the precision of guided surgery. My preference would be to have at least 2 millimeters, and what we see here is about 1.3 millimeters. And we should know that our drills, whether for guided or unguided surgery, are typically approximately 1 millimeter longer than the implant. So by the time we finish our drilling, we'll actually be within a half millimeter of the nerve there. So I would certainly be cognizant of that. And so that's a personal decision on comfort level there. And actually, on closer look, this nerve may actually be down here. So as I go through this slider right here, we can see the nerve canal right there. And you can see the inferior border of the nerve canal looks like to be right here. So the nerve canal may actually be like that. So again, again, we're not a planning service, so we just review the plans as they've been sent to us. But I would take a closer look at that. And one way of doing that is go through the axial view here, go to the bottom of the implant, and try to trace back the nerve from its exit. It's a tough one. It's hard to tell in this cross-sectional view. There could be some medullary cavities here. So I would better err on the safe side than on the not so safe side on this one. So again, a good case. Everything else looks good. Again, I would like to see some separation of the teeth. It helps in diagnosing and implant planning. Generally speaking, this implant is in a good space, especially as we look at an axial view. We can see everything there. And then the last thing I want to check is the sleeve position. And again, I'm not familiar with the Strawman system personally, so I do not know if you can do a guided surgery with the Strawman tissue level implant. But again, um, as someone who's more familiar with it in the planning person here, that'll be something to take a closer look into. So Thank you for submitting this case, and good luck with everything. And if we can be of any help, please let us know.